Hello everybody, my name's Sue Ross and I'm one of the hosts for this evening's presentation. I just wanted to welcome you to the room. We're going to be starting our presentation in just a moment. So it's my pleasure to be actually hosting this evening, and we're very fortunate tonight to have Dr. Gerard Lewis as our guest speaker. I'm sure that some of you know Dr. Lewis. He's a well-known cardiologist and practitioner from New Zealand, and he has over 40 years' experience in using both conventional and complementary medicine to prevent and treat disease. And he's currently in private consulting practice in Auckland. So we've got over 71 people in the room tonight, and I'm sure that there'll be some more people logging in a moment. So I will ask Dr. Lewis if he'd like to come on. I'll mute my microphone, and Dr. Lewis, if you'd like to come on now, we'd love to hear from you.
Thank you, Sue, very much. Welcome all those in Australia and also in New Zealand. I understand it's as cold over there as it is over here at the moment. What I wanted tonight to talk about is one of my specialties, which is coronary artery disease. And I want to look at it a slightly different way than most people do when we have doctors talking. I want to talk about, first of all, why it happens, how we can reduce it, and what doctors can do. And that's usually where the situation stops when you have most lectures. But what I want to do is I want to talk about what we can do, what you can do to prevent heart disease, and most importantly, how we can protect our children from developing heart disease and going through the same problems that our generation has gone through. Now, this is a picture of Monica and my fourth-year medical school class in Dunedin. We both went to Otago Medical School. That's Monica under the arrow on the left, me under the arrow on the right. And we graduated in 1967, and we did a lot of study at medical school. It takes 7 years to get through medical school, but soon after we graduated, we discovered that we had what we learned in medicine certainly wasn't enough for what we wanted to do looking after our patients, because most of the time we talked about diseases, how we could treat the symptoms, but we very rarely talked about how we can treat and cure the diseases. Most medical diseases these days, and certainly in those days as well, we could treat the symptoms. We could treat diabetes as long as you took the medication or your insulin. Your diabetes was controlled. As soon as you stopped it, the diabetes came back again. High blood pressure, the same. Take your pills, and as long as you're taking the pills, the blood pressure stays down. As soon as you stop the tablets, the blood pressure goes up again. So we were actually treating the symptoms, but we weren't treating the diseases. And soon after we left medical school, Monica particularly, and then I followed a little bit later on, following this course, we discovered there was a whole field of therapies outside of what we learned at medical school. We never heard about them. Alternative therapies, complementary medicine, all sorts of things, nutritional medicine, etc. Therapies that actually work with the body to create health rather than just simply treating the symptoms and suppressing the symptoms. And we've found that by bringing alternative medicine along with conventional medicine, we can actually start bringing the scales back again, and we can start talking about genuine health and preventing disease rather than simply picking up the pieces when the disease has developed. Now tonight we're talking about coronary artery disease, and this is a true story. Bob, it's not his name, but Bob was a fireman who I knew very well when I was working in Hawke's Bay. He was an Ironman. He did lots and lots of physical exercise. He was a runner. He won all the competitions. He ran Ironmans, did marathons, etc. He was 42, happily married with 3 young children, and was incredibly healthy. One day, Bob came home from a run. In fact, he ran home from work, which is what he always did. Sat down on a chair, then collapsed onto the floor, said, "I don't feel well," collapsed on the floor, and died. He'd had a heart attack. He'd had a cardiac arrest, which very frequently happens after a heart attack, and that's what caused him to collapse. His wife knew how to do CPR. She did CPR, but unfortunately it was unsuccessful, and Bob died. I went to his funeral in Hawke's Bay, which was incredibly sad because he was 42 and he had 3 little children. And a few weeks later, his widow came, along with her older child, and came to me and said, "What could we have done to have prevented this?" And I really couldn't give an answer. Bob didn't smoke. He was physically fit. He ate well. He did all the right things. And yet he was dying at the age of 42. And more importantly, she said, what do the children do? Because Bob's dad and Bob's grandfather also dropped dead of a heart attack suddenly without any warning. And unfortunately, at that time, I really had no answers because I hadn't gone through the complementary alternative, which I'm talking about today. But now we do have the answers. And we need to open our eyes. I think doctors need to open our eyes and look at what's in fact possible out there, because it can make a huge difference. And I only wish I'd been able to say this to Bob's wife about 30 years ago. Now, it's a commonly known fact that 1 person in 3 dies of heart disease. 1 person in 3 dies of heart disease, 1 person in 3 dies of cancer. But with heart disease, graveyards all around the world contain millions of people who have died before their time, just like Bob, perfectly physically fit and well, and then suddenly died when they had many years of productive life ahead of them. The tragedy is that coronary artery disease is a preventable disease. We can stop it from happening, and more importantly, or just equally importantly, we can make its effect less fatal. So Bob could have had the heart attack, but he didn't need to die. Think of heart disease as a disease of old people in their 50s, 60s, 70s, and 80s. But in actual fact, heart disease starts in our teens. That's an artery on the top left-hand corner there. And down the bottom of the artery, you can see the yellow material on the lining of the arteries, and that's cholesterol plaque building up on the inside of the artery. And that starts building up very young. In fact, they did a study, rather a strange study really. They examined the pilots who were killed in the Vietnamese and Korean wars. They flew Sabre jets at those times, and if those jets crashed, the pilots died, and they did post-mortems on them. And they discovered that over 42% of these fit young pilots, the cream of the United States Air Force at the age of 18, 19, and 20, over 42% had early signs of coronary artery disease. So this is a disease of young people, starts at young people. It's too late, or it's not too late, but it's better to start early rather than waiting, because what then happens is the plaque on the right-hand side here gradually builds up, gets bigger and bigger and bigger, and then finally a clot forms in the middle, and that blocks off, and that's what happens when you have a heart attack. But the important thing is this happens when we're young. Now, they found that in their teens. That means these kids, in fact, had probably started developing the disease even before their teens. For years and years and years, we've talked about cholesterol as being something evil and bad. Well, cholesterol is actually one of the most crucial compounds that we have in our bodies. We use cholesterol to make all of our cell walls. We need cholesterol to make a lot of the tissues inside our bodies. A lot of the hormones are made of cholesterol, as are a lot of the fluids that the tissues produce as well. So cholesterol is absolutely crucial. And we also need cholesterol to feed the artery wall. So cholesterol actually moves in and out of the artery wall, as you can see in this picture. And if it's needed, it's used. If it's not needed, it comes back into the artery wall. If, however, cholesterol gets oxidized, if it goes into the artery wall and then loses an electron for all sorts of reasons, it becomes irritable. And it's called a free radical. It sticks onto the artery wall, it damages the artery wall, and more importantly, it can't get out. And then more cholesterol comes in, sticks to that, and over time, a plaque develops, a little mountain of cholesterol gradually builds up, starting on the inside of the artery, getting bigger and bigger and bigger, and it builds up over 20 to 40 years. Now, the little plaque on the left-hand side is what they found in the Korean War, and then gradually it gets bigger until it starts causing symptoms, when it starts blocking the arteries. And these plaques can have a number of effects. First of all, they can reduce the blood flow coming down the artery. That's blood flow you can see with the red arrow there, and obviously less can get past that plaque. So that when you exercise, not as much blood goes through the artery as it should do. And if that artery is going to your leg, then it causes something called intermittent claudication, which is aching on the back of the calf. If the artery is the artery, Sue, can you mute your mic, please? If the artery is going to the heart, then it causes chest pain, tightness in the chest, and that causes angina. So basically, the bigger plaques, as the plaques get bigger, they start causing symptoms. Then we know they're there. But unfortunately, disease happens before the plaques necessarily get big enough for us to know. The second things that plaques can do is they're not very strong, and sometimes little pieces can break off and fly down upstream of the artery. And this is the major cause of strokes. On the bottom right-hand corner there, that's a angiogram of the artery. And if you've got a plaque in the wall of the carotid artery, and a little bit flies off, goes up the carotid artery, enters the brain, and as you can see, there's little white splodges on the MRI scan there, that's a stroke. And that's the major and the leading cause of strokes, is in fact these plaques flying off. So we're not just talking about heart disease, we're actually talking about reducing and preventing strokes as well. And finally, and what happens when you have a heart attack, is the plaque can rupture. Sometimes where that little green arrow is, sometimes a little crack develops in the plaque wall, some of the cholesterol inside leaks out, that becomes very irritable, and then on the right-hand side you can see that that little bit that leaked out makes the blood clot. A large clot forms, blocks the artery, and no blood goes down the artery, and it blocks the circulation. And this is the most common way people have a heart attack. And as you can see on the bottom right-hand corner there, you've got the coronary arteries, and where that arrow is pointing to, that's where the block is, and everywhere beyond that block gets no blood, and that part of the heart becomes damaged, and then eventually will die. And that's what happens when people have a heart attack. But the frightening thing, and the thing that people don't realize, is that plaques of any size can rupture. On the left-hand side, you've got a big plaque. That's one that may be causing symptoms. But on the right-hand side, you've only got a tiny little plaque. That doesn't make any difference at all, hardly, to the circulation. And they worked out that 70% of all heart attacks, of all ruptures, come from small plaques that are too small to cause any symptoms. And as they don't cause any symptoms, they don't reduce the blood flow, and they don't show on exercise testing. So a lot of people have regular exercise testing. That'll show those big plaques on the left, but it doesn't show the 70% plaques on the right. So exercise testing really does not help us prevent heart disease very much at all. So the artery becomes blocked. Part of the heart then becomes damaged. We've got that arrow pointing to the grey dart area. And what that then does is it makes the heart beat irregularly and unstable. And as you can see going along, and then where this little yellow lightning bolt has come, we get what's called an ectopic beat. And most people, when they've had a heart attack, get a lot of these ectopic beats. And if that ectopic beat on the lower trace here comes earlier and lands on the bump just after the major blip there, called the T wave, that produces ventricular fibrillation, which is a cardiac arrest, and that's in fact what happened to Bob. So if the ectopic beat happens at just the wrong time, ventricular fibrillation occurs. And it's been worked out that almost 50% of all heart attack patients at some stage have ventricular fibrillation. So it's the major cause of sudden death. Now this is a picture of Robin Norris. He's actually a Kiwi. He used to work in Green Lane Hospital before moving to the United States, to the United Kingdom. And he did a study in Oxford, the United Kingdom, and he studied everybody who had a heart attack in the three of the major cities in England, Brighton, Leeds, and South Glamorgan. Now, most studies look at people who come into the hospital, or they look at people in the mortuary, but they don't look at people who in fact died and have gone, for example, straight to the undertakers and things like this. He traced every single person that had a heart attack, and he produced this study, and he published it in on the book that you can see on the right-hand side there, which a lot of people have not read and don't know about. Now, we're not talking about third world countries and third world cities. These cities had top-class medical services, including superb ambulance services, and they even had, which I think is a fantastically good idea for cities with large populations and gridlock, etc. They actually had a lot of their paramedics going around on motorbikes as well. And the data that he produced actually was quite frightening. He looked at every single person in those three cities who had a heart attack, and 48% of all the patients who had a heart attack were dead within 4 weeks. Now we tend to think that in fact we've got heart disease under control. 48% of everybody who had a heart attack was dead within a month. Almost half of all those deaths were in people who were less than 60. And half of those who died had no warning. Just like Bob, the fireman, the first warning they had that they had heart disease was a sudden cardiac arrest, and they were dead. So in modern Britain and modern Australia, modern New Zealand is much the same. Almost half of all coronaries are fatal, so we need to stop them happening. They affect young people, and in 50% of people, the first warning people get that they've got any form of problem is they're dead. And this is one of the graphs taken from the paper, and I know Monica says you mustn't use graphs, but I think this is incredibly important. Up the left-hand side, we've got percentage of deaths, 60% up here, north of the bottom, and on the bottom we've got ages, less than 45, across to 70, 74 and above. And those in red are those people who died before they got to hospital, and those in blue are those who died in hospital, and the top line obviously is the combination of the two. And the frightening information is that almost everybody under the age of 55, where that arrow is, died before they reached hospital. If you look at the red line, nearly everybody under the age of 50 was dead before they got to hospital. So improving our hospital services, having wonderful cath labs, cardiac surgical units, even coronary care units, won't help reduce death in young people. The death of young people nearly always, because it's usually a small plaque that was asymptomatic, they die before they get to hospital. And the only way to save lives in younger people, but less than 60, is in actual fact to prevent the heart disease from happening in the first place, or, in addition, reducing the risk of them developing ventricular fibrillation. So what can we do in the 21st century to save lives of people in all ages? And what could I have said to Bob's wife and her son? We can do lots. We can prevent heart attacks from happening. We can improve our pre-hospital treatment so that patients actually get to hospital and can be treated in hospital, and we can improve our hospital treatments. And the last two we're doing very well, but we're doing very, very poorly in number one, preventing heart disease. But we'll start with pre-hospital treatment. What can we do, or more importantly, what can you do to help a patient who has a heart attack? Now, with a heart attack, what happens is a person gets a crushing, heavy chest pain. The sensation is usually, somebody says, it's like somebody sitting on their chest, or tightness around the throat and heaviness in the arms, sometimes through to the back. But usually the sensation is a heaviness in the chest. So number one is make the person comfortable. Now, people often try and force somebody to lie down or sit up or whatever you like. The patient knows what they want to be best. Let them do what they want to, but it's either lying or sitting. Many people find it's actually most comfortable just lying with their head slightly up. But first of all, make comfortable. If the patient's got nitrolingual spray, if they've had angina before, take a puff of spray, 2 puffs every 5 minutes until the ambulance comes. And then number 3 is call the ambulance. Now, it's a wee bit confusing because there are a whole lot of emergency services in New Zealand. It used to be 999 because we had these dial telephones, and it was very easy for a child to dial 111, but 999 was virtually impossible, so they reduced the number of children dialing for fun hugely. But now we've all got press button phones, that doesn't matter. In New Zealand it's 111, I think in Australia it's 000, in the UK it's 999, and in America, of all things, it's 911. But because lots of people watch television programs from all around the world, and depending on your country, people get confused, and it is very confusing. In almost every country, certainly Australia and New Zealand, if you dial any of those numbers, 999, 000, 111, or 911, they all go through to the emergency exchange. So, chest pain, make comfortable, puff of spray, call the ambulance. Number 3. Number 4 is stay with the patient and keep them calm. Now, if you can keep somebody calm and relaxed, it actually reduces the risk of them going to ventricular fibrillation. You don't have to do much. Don't sit there and chat, and don't start telling stories about people who've had heart attacks and how they recovered and things like that. Just simply sit there and hold their hand. You don't have to have a stethoscope around your neck. Just basically hold their hand. Try not to shake if you can, because that doesn't help in their confidence, but you've no idea what difference it makes just holding somebody either with one hand, or some people actually prefer putting a hand on top and a hand below, but just hold their hand and don't leave them, because that is important for a person. If the patient collapses, has a cardiac arrest, you need to check the pulse, which you can either check in the arm or in the neck, and then you should start doing CPR. Now, in the old days, CPR was exactly what it says, cardiopulmonary resuscitation. And we used to do mouth-to-mouth, which is on the top screen. We had to do mouth-to-mouth, and then cardiac chest compressions, which is on the bottom of the slide. Now, fortunately, they've now discovered that it's almost as efficient doing chest compressions. If you do chest compressions, you actually move air in and out of the lungs, and you don't have to do the mouth-to-mouth. Now, a lot of people actually didn't do CPR because they didn't like the feeling, or they didn't like the idea, the thought of doing mouth-to-mouth respiration on a total stranger, and a lot of people didn't do CPR from that. So now we don't do mouth-to-mouth at all, and it's just as effective. You just put two hands on the center of the chest like that, press down about 1 to 1.5 inches, about once a second, and you do that, and you can keep somebody alive for 10 to 15 minutes quite well. In fact, there's a picture on the right-hand side there of a little child. Now, this isn't the child that did it, but in actual fact, in the United States, the emergency telephone operator told the child how to do CPR, and the child actually did CPR, kept your daddy alive until the ambulance arrived. So CPR is easy, it works, and you can't do any harm. So that's what we can do, but then you basically need the ambulance to come as fast as possible because they've got oxygen, they've got drugs, but most of all importantly, they've got defibrillators as they've got in hospitals. And defibrillators essentially put a shock across the chest, get the heart back into its normal rhythm. And that's the most important thing for somebody who's had a cardiac arrest, is to get a defibrillator. And until recently, the only people who had those were hospital ambulances and hospitals. But now we've got these little advisory defibrillators which are present in many malls, anywhere where people congregate, airports, aeroplanes. Every 747 has an advisory defibrillator. Stadiums, and on the right-hand side you can see the arrow pointing. They've got them scattered around the walls of many, many places. And it's interesting if you go around just having a look, seeing when they are, because there now are lots and lots of them everywhere. And these are saving lives. And the exciting thing is, you can save lives. Now, you can forget about everything I say on this talk other than the next 3 slides. So concentrate on the next 3 slides because they're important. Defibrillators, and you can save lives. And as long as you can count to 3, you can use the defibrillators. Number 1, and they're labeled on the machine, number 1, switch it on. Press the little green button, it turns on. Number 2 is apply the pedals, and those are the pedals you can see beside there. They've got pictures on them telling you where to put them. One goes on the right-hand side of the chest, just above the right nipple. The other one below the left nipple, just under the armpit there. It doesn't matter if you're slightly wrong. It doesn't even matter if they're backwards. But just so it's across, so the current can go across the heart. The machine, and they're incredibly clever machines these days. Now in America, they're fantastically keen on suing every company they possibly can. So they've made these absolutely foolproof and totally safe. You cannot get these wrong. The machines won't let you do anything wrong. So you apply the pedals, that then analyzes the tracing, and you can see on the trace there, but you don't have to do this because the machine's doing it. You can see that patient has got ventricular fibrillation. So the unit will analyze that and say, recommend a shock, and then it says, stand back. So basically, if somebody's doing CPR, you would tell them to stop doing CPR, stand back, and then the machine will say, advise to shock, press button 3. So where that little green arrow is, you press button 3, that delivers a shock, like that. The shock stops the heart for 1 beat, and then the heart resumes back into its normal rhythm again. And you have just saved somebody's life. It is the most satisfying thing in the world. You've not only saved his life, or her life, but you've also given somebody back their mummy or their daddy, or their partner. It's incredibly satisfying. Don't be frightened of these machines. They can't get it wrong. And they are saving lives all around the world, but people aren't using them as much as they should be. So the ambulance then takes the patient to hospital, and in hospital we've got 2 treatments. We can open up the arteries. First of all, we can use thrombolysis. We basically inject a thrombolytic drug called Actylase or something like that. And that's the little green lines, green arrows there. That enters the circulation, comes along, and it dissolves the red clot and opens up the artery again. And if it's given early enough, it can hugely reduce the damage done to the heart. In fact, if you can actually get thrombolysis within half to 3/4 of an hour, you can stop the heart attack from happening altogether. So get to hospital as soon as you can so the thrombolytic drugs can be used. Is take the patient to the catheter lab and put a catheter in, put a little wire with a balloon through the narrowed area of the artery, blow the balloon up, and then blow the balloon down again, and you're left with a stent which has opened the artery wide up again. So we can do an angioplasty as well. That takes a little bit longer, and once again, it's important to do it quickly. And in fact, the message is minutes equals muscle. Every minute wasted, more muscle dies. And so basically, try and get the patient to the hospital ASAP as soon as possible. Don't wait. A lot of people think, you know, I don't want to waste the hospital's time, and I don't want to do false alarms, etc. If somebody continues to have chest pain after 10 to 15 minutes, call 111. Tell the ambulance this person has got chest pain, which means they'll come along with the lights on and the sirens going, and get the person to hospital as fast as they can so they can either have thrombolysis or angioplasty as soon as they arrive. This is important, and once again, this can save lives. Time equals muscle. So that's what we can do before the patient gets to hospital. That's what we can do in hospital. It's far, far better. This is all ambulances quite literally at the bottom of the cliff. What we need to do is prevent heart attacks from happening in the first place. Now we've got a number of treatments in medicine. We've got drugs, we've got angioplasty and stenting, which we've talked about. That doesn't actually reduce and prevent heart attacks. It just relieves pain. Bypass surgery, in a few people it reduces heart disease, but not very many. It just once again reduces symptoms, and heart transplant obviously is the end of the line, and that's nothing that people particularly want to consider. But the most important thing in medicine, in fact, is our drugs. Aspirin, cholesterol-lowering drugs. Aspirin, and it's a low dose of aspirin, it's only 100 milligrams. Most aspirins you take for a headache are 300 milligrams, and the aspirins work on the platelets. It stops them clotting so that when the plaque ruptures, a clot doesn't form so well. And there's been debate. There's been all sorts of studies done on aspirin, and we really still don't know the answer. Some people suggest that everybody over the age of 50 should be on an aspirin. Some people say that nobody over the age of 50 should be on aspirin because it may cause gastric irritation and bleeding. We don't know the answer, but I think probably the answer really is that anybody at high risk of heart disease should probably take a low dose of aspirin. And if you've had a heart attack or had a stroke or you've got angina or any form of artery disease, then most people these days are put on aspirin. And the second group of drugs we've got are the drugs that lower cholesterol. And we've got a lot of drugs that do that. We've got fibrates, which we've had for years, resins, we've had these for years. There's Atimbi, which is a newer drug, and we've got the statin drugs. Now, all of these drugs lower the cholesterol. They've all got side effects and they've all got dangers. But interestingly, only the statins have been shown to reduce heart disease. Fibrates, resins, Atimbi, they reduce cholesterol, but they have not been shown to reduce the development of heart disease. Only statins have actually been shown to reduce heart disease. And the main statin drugs are Lipix, Zocor, Lipitor. These actually are the most profitable drugs in history. Merck, Sharp and Dohme and Pfizer have made an absolute fortune with these drugs. And as you know, they're being pushed to be used by people all around the world, and they're recommending more and more people take statins. Simply, I think, well, simply I know, because the profit people are making out of it is huge. They do reduce heart disease, but they don't necessarily do it by lowering cholesterol, because they do all sorts of other things. They improve the endothelial function up the top there, which is the lining of the inside of the arteries. They stop thrombosis in the artery itself. They've got an anti-inflammatory effect, which is probably the most important effect they have. They modulate the immune system, bottom right-hand corner there. They're antioxidants, which again is anti-inflammatory, but antioxidants. They protect the vascular cell wall. They help produce new blood vessels, and they also stabilize plaque. So in addition to lowering cholesterol, statins do all sorts of other things as well. And it almost certainly is not the cholesterol action that makes statins work. So should we be recommending people to take statins? Now, trials have shown that most people who take statins, there's a 20 to 30% reduction in heart attacks, stroke and death. Now, that sounds a lot. But if you've got a 10% risk of having a heart attack, then a 20% reduction of that 10% is 8%. So you go from 10% to 8%. So it's only a tiny little difference. If, however, you've got a 60% risk of having a heart attack, then a 20% reduction is very major. So essentially, it's better to use them only in people at high risk. And the other thing is statin drugs undoubtedly do have significant side effects and toxic effects as well. And they've been underplayed. They've got real problems. So there's very little evidence in actual fact that there's a much benefit in prevention of heart disease in women. This is in part because a lot of the early trials didn't include women. I have no idea why, but they didn't. But even the trials that have included women, they've had less benefit than, in fact, men seem to in preventing heart disease. There's definite evidence that, in fact, statins do cause or increase the incidence of diabetes. So if there's a diabetic tendency, and you've got a diabetic tendency in the family, or even highest blood sugars, you need to think very hard about putting somebody on a statin. They've also got real side effects. Muscle pains, myopathy, which is very, very common. And these are aching muscles, and if you get aching muscles and you're on a statin drug, you probably should stop taking the statin drug and talk to your doctor about it. They can affect the nerves. You can get pins and needles and abnormal nerve function. The one which is probably the most frightening and the one that people don't realize is the effect they can have on the brain, particularly in older people. They can almost give you an Alzheimer's type syndrome or symptoms, so that people don't, their memory isn't as good, their ability to do things isn't as good. And people think they're getting older, but if they stop their statin drugs, suddenly their mind starts clearing again. So if you're on statin drugs and you've got mental problems, or you know people on statin drugs on mental problems, consider stopping them for a month and see if it makes a difference. We know they cause liver damage, but we can test that with a liver function test. The other thing they do is block the production of something called coenzyme Q10, which I'll talk about in a minute or two. But on the right-hand side there, we've got how cholesterol is developed. It comes from acetyl-CoA at the top. In the metabolic system, down through HMG, CoA, paramylate, down, so on the left-hand side, it blocks the pathway. Block the development of cholesterol, but they also block the production of coenzyme Q10, which is very important in heart disease, particularly as we're getting older. So my advice, going down to the lines on the left-hand side again, my advice is take statin drugs if the risk is high. Certainly if you've had a heart attack, strokes, or any condition like that, or any form of vascular condition, undoubtedly people should take statin drugs if they can. If you get side effects, then I think you need to think very hard about taking the drugs, or depending how severe the side effects are, and maybe try another statin. But if there are no side effects, then I think it is beneficial to take them if your risk is high. And I think it's also important always to take a good coenzyme Q10 as well, because the statin drugs will reduce the coenzyme Q10 in the body. And I'll talk about coenzyme Q10 in a minute or two. So that's what doctors can do with drugs. But complementary alternative therapies, there are lots of them, and they are more powerful, more effective, and they work than conventional medical treatment, and certainly more effective than drugs. What we can do, regular mild exercise, and I'll talk about these all in a minute, most of them in a minute or two, reduce weight towards the ideal, sensible use of alcohol, optimal nutrition and supplements, fish oils for both heart and rhythm, selenium, calcium and magnesium, EECP, which is a balloon counter pulsation for improving the circulation. Chelation therapy probably only works when people who've got diabetes. Interestingly, in men, testosterone therapy can reduce the incidence of heart disease, and coenzyme Q10 is also beneficial. Now, obviously, I haven't got time to go through all of these, but I'll go through some of them now. The first three, mild, regular exercise. Now, you don't need to put on leotards and jump up and down in the gym and go for marathons and things like this. Just simply get a decent-sized dog, take it for a regular walk. That sort of exercise is as good as any other exercise. And regular walking is incredibly beneficial for all sorts of situations, but especially heart disease. It's also beneficial to reduce the weight towards the ideal. It drives the blood pressure, it lowers the cholesterol, it lowers a number of the other components of cholesterol as well. Now, there are two sorts of obesity. There's obesity where it's the tummy, which contains the fat, and that's the apple shape. And there's the pear shape, which is where it's the bottom and the thighs. That's actually good fat. And that, in fact, is beneficial fat down there, but it's the abdominal fat that is the problem. So reduce weight towards the ideal, particularly trying to get rid of the tummies that most of us tend to develop as we get older. Alcohol is a two-edged sword. In fact, there's quite good evidence that one or two glasses of alcohol most days can actually reduce the incidence of developing heart disease. More makes heart attacks more. I don't think it's strong enough to suggest everybody should drink, but nevertheless a little bit of alcohol certainly is beneficial. But then, as I said, it's a two-edged sword. It increases the risk of heart failure, and also in women it increases the risk of breast cancer. So alcohol, if you enjoy alcohol, one or two glasses, but no more, but it's not compulsory. The next one is optimal nutrition and supplements. Now, the artery wall isn't just simply a lining there, a smooth lining that the blood vessels, that blood goes through. In fact, it's an incredibly active thing that is taking tissues from the blood into the artery wall and shunting it around the body, etc. The artery wall is very, very active. It's one of the most active areas of the body, in actual fact. And the artery wall needs all the nutrients it needs to function as well as it should do. And also if it gets damaged, and you've got blood going there, pumping at 120 to 150 millimeters of mercury, damaging the artery walls, producing cracks and things, the artery needs all the nutrition it needs, both to function as well as it can, and also to recover from damage. And we can get that with a good, balanced, low-carbohydrate diet. Now we now know, and doctors are beginning to realize, we've actually nailed the wrong flag to the masthead. We've been saying that cholesterol and fats are the baddies. There is no debate at all now. You read any cardiological journal, most other medical journals, and they'll agree with you that carbohydrates are the problem of disease, and carbohydrates, in fact, are the cause of a lot of artery disease, diabetes, etc. So a good, well-balanced, low-carbohydrate diet, lots of fruit and vegetables which contain antioxidants and a lot of the other materials that the arteries need. Meat's important if you can. You don't have to, but it does give a lot of nutrients. And it's also fish and fish oils. If you can't take fish oils, flaxseed oil probably is as good. But we also need all the vitamins and all the minerals we need. And if you don't get that in your food, then you probably need to take a regular supplement. And unfortunately in today's world we don't get enough in our food, and I think everybody should be taking a regular multivitamin, multi-mineral supplement every day. Fish oils. Fish oils have an enormous benefit on the heart, both on developing heart disease, but also on the rhythm, stopping patients going into ventricular fibrillation, which is what killed Bob and kills 50% of people who have a heart attack. Now, when I was doing my PhD in London, in fact, I was doing some work with these fish oils and working with a chap who had actually been trying to stop ventricular fibrillation in a number of animals, including rats, monkeys, and dogs. And if you give rats, monkeys, and dogs enough fish oils, you cannot produce ventricular fibrillation. It raises the fibrillation threshold. So certainly if you're going to have a heart attack, make sure you've got plenty of fish oil on board, because it reduces the risk of developing ventricular fibrillation. And there have been a number of studies. The USA Nurses study, 44% fewer cardiac deaths. United States Doctors study reduced sudden death by 81%. And the GISSP study, a 45% reduction in sudden death. So fish oils actually make an enormous difference, 40 to 80% reduction in heart attacks and sudden death. And calcium and magnesium. Our muscles, both the muscles in our bodies, all the muscles you can see at the top left-hand corner there, and also the muscles of the heart are the same thing. And for the muscles to contract and relax, they need calcium and magnesium. And when calcium comes in, the muscle contracts. The muscle basically consists of like two ladders, and they slide into each other when the muscle contracts, and they slide out when the muscle relaxes. And when calcium comes in, the ladders slide together, and the muscle contracts. When calcium comes out, magnesium goes in, the muscles relax as the ladders slide apart again. And heart muscle is exactly the same. Magnesium helps the heart muscle to relax and makes it more stable. It also does the same for nerves as well. And there are lots and lots of papers showing the protective effect of magnesium in heart disease. It reduces high blood pressure. Anybody with high blood pressure, I always start them on magnesium. It relaxes the smooth muscle in the little arteries and can actually lower blood pressure by itself. It's a fabulous treatment for palpitations. Again, people with palpitations, magnesium is my first treatment. Patients with heart failure, it helps relax the muscles. Coronary artery spasm, it stops chest pains, and it reduces the incidence of sudden death. And everybody with any risk of heart disease should be taking at least 500 to 800 milligrams of magnesium per day, and the only real way of guaranteeing that is to take a good quality supplement that contains that amount of magnesium. Now, we talked about coenzyme Q10 a few minutes ago. Now, coenzyme Q10 is crucial to the heart, and once again, we didn't learn about this at medical school, and a lot of doctors don't know about it. But when the heart muscles contract, they need energy to do so. And that energy is made by glucose and fats, which are burnt in the little mitochondria, which on the bottom right-hand corner, you've got a thing that looks a little bit like an open capsule. Those are the mitochondria, and they burn the glucose and fats, and they create energy. And those mitochondria are those little red things you see scattered all over the muscle fiber on the left-hand side of the picture. And energy's got to get from the mitochondria to the muscle fibers for the muscle fibers to work. And the coenzyme Q10 carries the energy from the muscle fiber, from the mitochondria to the muscle fibers. It's a little bit like a power plant creating energy, and the wires from the power plant to the factory so the factory can work. And at the bottom left-hand corner, our power plant is the mitochondria, and the coenzyme Q10 is the equivalent of the wires taking the energy to the muscle fibers so the muscle fibers can work. So coenzyme Q10 delivers the energy to the muscle fibers and is very, very important. So you start blocking that with statin drugs, in fact, you're doing a lot of harm. And it also helps in the treatment of heart failure. It's very effective. There's a study that's actually just come out halfway through this year called the Q-Symbio trial, and they looked at patients with severe heart failure, and half they gave dummy coenzyme Q10, the other half they gave coenzyme Q10, and the dummies are the blue, and the patients who got coenzyme Q10 are the brown ones. And as you can see, it halved hospitalization, and it almost halved the deaths. Now, we haven't one drug that can do anything like this for heart failure, and yet most patients who've got heart failure are not given the option of receiving coenzyme Q10, which in this study and other studies too has been shown halves hospitalization and halves deaths. Now, when we take supplements, just like taking food, you really don't see the effects most of the time. But all they do is support the body function, so the body works as well as it possibly can do. But occasionally the effects can be almost miraculous. Now, I've been in the last few years, you said I'm doing a private practice in Auckland, but I've also been doing locum practices. A lot of the smaller hospitals around the country need physicians to help them every now and again. So I do locums there, and I did one, the top left-hand corner there. The top star is Whangarei Hospital, and the right-hand star was Whakatane Hospital. And I'd like just to talk about a couple of patients. These aren't the actual patients, but they looked extremely like these people and what happened to them. First of all, at Whangarei Hospital, I was on call in the coronary care unit for the weekend, and I was called late on a Friday night by the nurses in coronary care unit who were absolutely distraught. They had a 75-year-old lady there who was having recurrent cardiac arrests, and that trace on the right-hand side there shows what happened. Every time her heart went into ventricular fibrillation, she went unconscious and had to be shocked back to bring her heart back to the normal situation. And they had tried every drug that they knew about, amiodarone, flecainide, procainamide. You don't need to know those names. They're all long. They tried every single drug they had. She had been defibrillated over 10 times. In other words, she had died 10 times and had been brought back 10 times. She was understandably petrified because she knew this would happen, and she'd just faint unconscious. She'd receive the shock, which of course she was unconscious, and she didn't feel it, and then she came back again, and it all started again. The nurses, of course, were at their wits' end. You know, how much longer can we do this? But then we can't just watch this lovely lady die with a disease that we can treat with a defibrillator. So they didn't know what to do. I added one treatment, just one, and the cardiac arrest stopped immediately. What did I give her? Intravenous magnesium. That's what I gave. It was intravenous magnesium. The ventricular fibrillation stopped. Next day she was sitting up happily in bed, and she went home and is now still living a happy life up in Whangarei Hospital. Brian, and again this isn't Brian, but Brian looked remarkably like us. We met in Whakatane Hospital in November 2012. He had had a number of heart attacks beforehand. He had a thing called a cardiomyopathy, which his heart was hardly beating. I did an echocardiogram, and you could only just see his heart beating a little bit. There were no operations possible. He was on every drug that we possibly had, digoxin, ACE inhibitors, beta blockers, diuretics, aspirins. He was bedridden, and the nurses couldn't measure his blood pressure. You could just feel his pulse, but you couldn't measure his blood pressure, and they kept ringing, "Doctor, what can we do? We can't measure his blood pressure." So I said, well, stop all the observations. Absolutely no point in ringing me, and there's no point in doing that because we can't do anything about that. And he had been told that he was going to go to a hospice for his last few days. And again, I was on for that weekend. But Brian wanted to see his daughters. He was an Englishman, and his daughters were coming out to New Zealand, and they were flying out from the UK for Christmas. As you see, this was November 2012. But he was told he had just a couple of days left, a week at the most. And the plan, in fact, had been for him to be discharged to hospitals for his last few days on this planet. I offered him one natural therapy, one drug, one pill, actually. Oh no, three pills, but the same pill times 3. 3 months later, he was enjoying New Zealand. He had Christmas with his daughters, and he was showing his daughters all around New Zealand. In fact, he died a couple of years later, but he had 2 years of incredible happiness, and I got these incredible letters from his daughter saying how grateful they were. One therapy. What was that therapy? Coenzyme Q10. Just that was all he needed. There was nothing taking the energy from his mitochondria to his cardiac muscle cells, and that's what he needed, in actual fact, for his heart to function properly. So supplements can make an enormous. Okay, so that can treat diseases. Have you got any proof that good nutrition will help reduce the incidence and the dangers of heart disease? And the answer is yes, we do. We've got the answers from our grandparents and the great-grandparents, people living in the Pacific Islands and people in the Mediterranean. Now, although our great-parents and grandparents often, the mortality was quite high, the mortality was mainly in children giving birth, mothers giving birth, children dying young. If you reached your 20s and 30s, in actual fact, the average life expectancy of our grandparents, great-grandparents, and before that was in fact 70 to 80, and they lived long, long years. And for them, heart disease, coronary artery disease was incredibly rare. I don't know if you did, but certainly I can remember my grandmother, the roast that she used to create had the Heart Foundation in epileptic fits. It was covered in fat. We had the most magnificent crunchy potatoes, rich gravy, fatty meat, cream, and everything else like that. But coronary artery disease was incredibly rare in those days. In fact, that's a picture of Dunedin Hospital, the bottom left-hand corner there, where Monica and I did our medical practice. When we graduated in 1967, coronary artery disease was so rare, there was no coronary care unit in Dunedin Hospital. So it didn't affect our parents and our great-grandparents and great-grandparents. People living in the Pacific Islands. This is Rarotonga. I don't know if you've been to Rarotonga. It's a lovely island. In fact, there's only one road. It goes right around the outside, and there's 2 buses. One goes round clockwise, that's the clockwise bus, and one goes around the other way, the anti-clockwise bus, and you decide which one you go on, and that's how you go around Rarotonga. But it's a beautiful island, and they eat lots and lots of fresh fruit, ripened on the trees, magnificent fruit, and fish. And I visited Rarotonga Hospital because I was doing work with Maori when I was in Napier. And Maori in New Zealand had huge problems with heart disease. And I went to the doctors over there because the Rarotonga people are Maori. And I said, how many heart attacks have you had in the last few years? And the doctor in charge of Rarotonga Hospital said, we've had 1. And that one person was in fact a French tourist. He said, coronary artery disease is not a disease of Polynesian people. And yet in New Zealand Maori, 1/3 of all Maori have heart disease. 1 in 3 dies of a heart attack. The Cook Island Maori are exactly the same people. They had 0. The only difference is it was slightly warmer, but that doesn't make a difference to heart disease. The only other difference was the diet they ate. Now the Maori, we believe, either came from China or Taiwan. They came across on that red line to the Cook Islands. And the wise ones stayed in the Cook Islands. Those who wanted to get a bit colder took the trip down to New Zealand. But the New Zealand and the Cook Island Maori are identical people, but the incidence of heart disease is enormously different simply because of what they eat. And the people in the Mediterranean, they eat lots of fresh fruit, vegetables, nuts, olive oil, wine, and fish. And all around the upper Mediterranean, that's the main diet, and the incidence of heart disease is incredibly different. This is a graph from the United Nations 1995-96 deaths of heart disease per 100,000 population. And as you can see, New Zealand's near the top, 127. Australia, slightly better, 110. But look down the bottom, France, 39. Just above France, Spain, Portugal, Italy, Greece. Those countries had much less heart disease, incredibly amount less. Now, they've got as much blood pressure as us. They smoke probably more than we do. They exercise less than we. They play rugby. They don't play cricket. But apart from that, they're almost identical in many ways, but the amount of heart disease is much less, and the only difference is in what they eat. So would it work today if we ate like our grandparents, like the island people did, or the people in the Mediterranean? And unfortunately, even if we ate exactly the same food, it's not the same as it was. You know, they used to eat free-range or free-swimming fish, not fish, salmon, farmed, full of hormones, colouring, antibiotics, fed with chicken and everything else. They get fed, the fish are supposed to eat algae, which contain the omega-3 oils. They ate fresh fruit, ripened, fresh, and in multiple amounts, full of vitamins and antioxidants, not sprayed fruit that's dry, that's picked early. They ate chicken that was basically in cattle that were free range, not inside in these terrible barns, etc. They ate whole grain meal, whole grain bread, not over processed bread. The same thing with rice, brown rice, not white rice. And they ate fruit and vegetables that were ripened on the tree, not gas ripened, because it's the ripening that in actual fact sells by the sun that sets most of the vitamins inside the fruit. So if you get gas ripened fruit, you don't get nearly as many vitamins or nutrients. So today's food is so poor, and unless we've got our own organic farm, we could actually never copy what happens in those countries or in those times. The only way we can actually make sure we're getting all the nutrients that they were is to supplement our diet, to make sure that our bodies have got all they require. Now we supplement. In New Zealand we used to have epidemics, in fact there was an epidemic of goiter, because there's not much iodine in our soil, so we've actually put iodine in our salt, and iodized salt to stop goiter happening. I'm not sure if it happens in Oz, but I suspect it might do. And if women are pregnant, they all take supplements for folic acid, because again there's not enough in our diet. So we're used to supplementing in some situations, but somehow we have a blinkers on about supplementing properly. So what would happen to heart disease if we took supplements? Now there are a lot of trials that in actual fact have showed that supplements do reduce heart disease. The trials show that antioxidants, fish oils, selenium, CoQ10, folic acid, magnesium, vitamin C all reduce either heart disease or the effects of heart disease. And we in the medical profession totally ignore them simply because they're either not published in the proper journals or they get no publicity. So let's just look at a few of those. The antioxidant supplements. Remember, it's oxidation of cholesterol that starts the whole process early on in our childhood and early teens. It's the oxidation of the cholesterol that starts the process. If we take antioxidants, which is found in fruit, vegetables, and antioxidant vitamins, we can actually stop this. And in the Harvard University, they actually did a study called the USA Nurses Study, and they looked at all aspects of these nurses' lives, including supplements. The reason they did the study, in fact, they followed 88,000 nurses from 1974 to find out what happened, because at that time the pharmaceutical industry introduced the pill, and nobody had any idea what the pill was going to do to these nurses, so they were followed by Harvard University. And they looked, because you had to look at the pill and everything else, they looked at everything else that happened to those nurses, including the supplements that they took. And in the nurses, heart attacks and deaths were reduced in the nurses taking supplements. Multivitamins, 31% less. Vitamin E, 41% less. Vitamin C, 28% less. Fish oils. There have been lots and lots of trials with fish oils, and we talked about this a little bit earlier on. But fish oils, as I said, reduce the risk of developing ventricular fibrillation, which is a cardiac arrest. And the red line is the controls, that's 100%. And in these trials, the GISIP, which is in Italy, in people who'd had a heart attack, the yellow was those that took fish oils. They had a 45% compared to 100% of sudden death. In an Indian study, the reduce was halved. Western Electric study in America was halved. USA Physicians study, 81% less sudden death. And in Seattle, it was 50% less. So you can reduce cardiac arrest and sudden death simply by taking fish oils. Everybody at any risk of heart disease should be taking fish oils. So reducing heart disease is so simple. We need to eat as well as we can. Supplements is not an excuse for not eating as well as we can. We need to eat lots and lots of fresh fruit and vegetables, and we need to show our kids how exciting and what fun it is to eat good fresh food. We need to eat fish. The Mediterranean type diet undoubtedly is the best. We need to take supplements to make sure that all the nutrients we need that's not in our diet is provided. Now, a good supplement will provide what you need, and what you don't need, it will be excreted. So basically, eat as well as you can, take a good supplement, avoid toxins and smoking, which is pretty self-explanatory, and regular exercise. And again, regular exercise does not have to be hard exercise. It needs to be fun exercising, so you'll do it most days. But remember, heart disease starts in our teens, so it's too late. Well, it's not too late, but it's better to start much earlier than those gentlemen on the top left-hand, right-hand corner there. We need to start doing all of these in our teen years. In fact, we should start doing it from childhood. Now, it's very hard to get kids to eat what should be good for them. Our teens, they love eating all sorts of things like this, which you know are not good for them, and although there's a little bit of green lettuce there, there's not much else there that contains antioxidants and minerals and vitamins. Then as we get older, all through life, we eat good food, but unfortunately our selection is not poor, and then as we get older, our selection of food, in fact, is worse. So the chance of getting all the vitamins and nutrients our bodies need is not very high. So we should take supplements at all stages of life. Children should take a child's multi and a child's fish oil. And these are nice if they're good ones. The kids love them. Our grandchildren, they can't. In fact, it's hard to stop them taking more than their daily dose. Teens should be taking a good teen multi. They should be taking fish oils, and probably should be, girls particularly, should be taking calcium and magnesium. All adults should be taking a regular multi, a regular fish oil, and regular calcium and magnesium. And for older people, they must be taking a regular multi, regular fish oils, and regular calcium and magnesium. If we did that, we'd have a diet almost as healthy as the Mediterraneans. And the Kiwis and the kangaroos would quietly slip down and have the same incidence of heart disease as the French do. And there's absolutely no reason why that shouldn't happen, provided we start doing it early enough. And that's what we should have been told in medical school. We should have been told this as well as all the other things we were informed about. It's so simple. Eat as well as you can. Take supplements to complete the diet and make it complete. Avoid toxins and smokes. And regular exercise. It's never too late to start, but it's much, much better if we start it in childhood. Now, we insist that our children clean their teeth. We insist they wash their hands. We should insist and make it a routine habit all through life to take a good multi and fish oils. And the exciting thing is, not only will it reduce heart disease, but there's good evidence that that sort of lifestyle and diet and supplements will reduce cancer, most immune diseases, nerve diseases, diabetes, and most other diseases that are affecting our world today. So thank you all for listening. This is my website if you want to read it, www.drgerald.co.nz. And down the left-hand side, I've got a list there of most of the diseases that I can think of, and I put there my thoughts about how they should be treated, both with conventional medicine and also the complementary treatment. And if you've got any questions or any comments or thoughts you want, that's my email address there, geraldlewis@zoho.com. So thank you all for listening. Good night.